Hi guys. So in today's lecture we will try to save a millionaire. Not millionaire by money but millionaire by number of neurons. So we are going to study treatment of ischemic strokes. Right. So here you can appreciate thrombotic and embolic stroke, and by now you guys know that these are various types of ischemic stroke. In thrombotic stroke there will be ischemia, but this ischemia will be mainly due to formation of clot in the arteries of brain itself, whereas in case of embolic stroke there will be formation of clot elsewhere, particularly in heart, and later on this clot migrates into the blood vessels of brain, resulting into thromboembolism, resulting into embolic stroke. So basically you have two types of ischemic stroke, that is thrombotic and embolic. In thrombotic and embolic, basic treatment is same. If patient presents within 4.5 hours of onset of neurological deficits, you have to treat this patient primarily with help of thrombolysis, that is with help of fibrinolytics. Okay, if patient presents after 4.5 hours, then thrombolysis might not be the ideal treatment, then you can go for thrombectomy. So this is basic understanding, but we need to discuss this particularly important topic in detail. Here you can appreciate thrombotic and embolic stroke. In embolic stroke there can be also use of anticoagulants. Okay, we have already discussed the treatment of transient ischemic attack. We have already discussed the treatment of hemorrhagic stroke, which includes subarachnoid hemorrhage as well as intracerebral hemorrhage. Right now, let's take a scenario. Suppose 75-year-old person presents to your emergency with history of right-sided hemiparesis. So this person is having right-sided hemiparesis. Let me give other things as well. And this is associated with lack of speech, that is improper speech. It means that this person might be having ischemic stroke involving middle cerebral artery, particularly of the left side, and the lobe involved over here is your mainly parietal lobe, right? Along with this person might also have features of acalculia, right? Along with the features of left right disorientation. Suppose this patient presents to your emergency after 1.5 hours of onset of focal neurological deficits. Now you have to manage this particular patient. So your first and foremost steps would be to go for plain CT head. If in plain CT head you observe no change, or if in this case you observe that there is hypodensity, you can conclude that this patient is having ischemic stroke, because in early stages there can be no CT scan finding. CT scan can be absolutely normal. Later on, with development of edema, this patient will develop hypodensity in CT scan, and treatment of ischemic stroke is thrombolysis if patient presents within 4.5 hours of the onset of stroke. So we will discuss this particular case as per this example. Okay. Right, here you can appreciate plain CT head, and this is normal CT scan. Okay, we have already discussed about transient ischemic attack, and this is normal CT scan. There is no hypodensity, there is no hyperdensity. In case there is hyperdensity, you can relate that finding to hemorrhagic stroke. If there is hypodensity, it relates to ischemic stroke, but in this particular case there is no hypodensity. Okay, suppose taking the previous example, suppose this patient has focal neurological deficits, and this patient has presented after 1.5 hours, and there is no improvement, there is no automatic improvement. Because there is no improvement and 1.5 hours has passed, therefore you can conclude that this is not TIA, right? Even if there is normal CT scan finding, because edema formation takes some time to develop, therefore CT scan can be normal. But if there is presence of focal neurological deficit which has not improved at all even after 1 hour, here I have taken 1.5 hour, it means that it is not TIA. In TIA, improvement starts within first hour itself, and it improves completely within first day, that is within 24 hours. So because this patient has shown no improvement and CT scan comes out to be normal, even then you have to diagnose this case as ischemic stroke and you have to provide thrombolysis to this patient provided that patient falls in the criteria of thrombolysis. Okay, we will discuss. Here you can appreciate almost normal CT scan, but this is not normal. Let me zoom this particular thing. Here you can appreciate your gray matter and this is your white matter. So you can appreciate gray and white matter in this particular hemisphere. Whereas in this particular hemisphere, you cannot appreciate differentiation of gray and white matter. So this is one of the earliest changes present in CT scan of ischemic stroke. Okay. Whereas over period of time, there will be development of frank hypodensity. This frank hypodensity is clear-cut sign in CT scan for ischemic stroke. So this is typical CT scan finding which is suggestive of ischemic stroke. Let's consider that our patient presented after 1.5 hours and you could figure out such type of hypodensity. Then there is no confusion that this person is having ischemic stroke and then you can move forward with thrombolysis. Meanwhile, you can also go for carotid angiography to localize the affected vessel and also plan for thrombectomy. But first treatment should be your thrombolysis followed by thrombectomy. If 4.5 hours has passed, then you have to think of thrombectomy instead of thrombolysis. Okay, here you can appreciate hyperdensity. If there is hyperdensity, we have already discussed, then it is not candidate of thrombolysis because this hyperdensity is suggestive of hemorrhagic stroke. That's why in case of patients of stroke, your first investigation should be plain CT head. This will help you differentiate between ischemic stroke from hemorrhagic stroke, and with help of clinical features you can differentiate ischemic stroke from transient ischemic events provided that your CT scan is normal. Okay, here you can appreciate CT angiography. CT angiography is needed to localize the lesion, to localize the blood vessel obstruction, and after you have localized the blood vessel obstruction you can proceed with thrombectomy, that is clot removal. Too simple to understand, right? Let's proceed. Now, try to understand few important things over here. Suppose your patient presented after 1.5 hours of development of focal neurological deficits, right? Now, how you are going to proceed? See, if there is no improvement, because already more than 1.5 hours have passed, therefore this is not TIA. Now this can be due to ischemic stroke or this can be due to hemorrhagic stroke. See, this can be figured out with help of plain CT head, right? Suppose your patient is having hypodensity. Now this is clear cut case of ischemic stroke. Okay, so you have guidelines for the time for the CT scan, for the interpretation of the CT scan, and because we are dealing with ischemic stroke, therefore thrombolysis has to be done first, followed by CT angiography, followed by thrombectomy. Okay, so let me explain one particular thing. What is door to CT time? Door to CT time is less than 20 minutes, right? And what is door to CT interpretation time? This is less than 45 minutes. And now let's also talk about door to needle time. And door to needle time should be less than 1 hour. So this is again important guideline in relation to investigation and management of ischemic stroke. Okay, this has to be remembered. Let's proceed. Here you can appreciate treatment of ischemic stroke. It has to start with thrombolysis. After thrombolysis, you can also go for CT angiography. You can localize the vessel, and here you can appreciate that the final treatment will be mechanical thrombectomy. This has to be done if patient has presented within 4.5 hours of onset of focal neurological deficits. Okay, but if patient has presented beyond 6 hours of appearance of focal neurological deficits, now there is no need of thrombolysis. Whatever damage could have been done has already been done. Therefore, in this case, there will be only one option, that is only thrombectomy on the basis of CT angiography of internal carotid artery. Okay, too simple to understand. So you have to provide thrombolysis, that is you have to provide tissue plasminogen activators, and here you can go for mechanical thrombectomy on the basis of your CT angiography, and later on you have to give adjunctive treatment in form of antiplatelet drugs, And if you are dealing with embolic stroke, you can also go for anticoagulants, particularly low molecular weight heparin. Plus statins can also be given because this particular disease is related to hyperlipidemia as well. And after all, you have to also control the hypertension and diabetes. Okay, here you can appreciate this golden time, that is less than 4.5 hours. So ideal time of thrombolysis, ideally with help of tissue plasminogen activators, has to be done within 4.5 hours, right? But it can be done up to 6 hours, right? Then you need to go for CT angiography, right? And as per findings of CT angiography, you can go for mechanical thrombectomy, right? Mechanical thrombectomy. So as per protocol, this is the treatment if patient presents within 4.5 hours or maximum up to 6 hours. But if patient presents after 6 hours, then you are left with only one option, that is go for CT angio, and on the basis of CT angio you can plan mechanical thrombectomy, right? So let's see the protocol. First of all, you have to decide whether it is a stroke or transient ischemic attack. If your CT is normal, even then it can be stroke. I am talking about ischemic stroke. Okay, so here you can decide whether the patient is candidate of tissue plasminogen activator or not. That is your thrombolysis, that is your fibrinolysis with help of tissue plasminogen activator, example retiplase and alteplase. Too simple to understand. These are clot buster agents, these are clot dissolving agents. Okay, right. If this patient is candidate of IV tissue plasminogen activators, it means that this patient has presented before 4.5 hours ideally. So in this particular case you can give IV thrombolytics, right? Nowadays it is needed to go for CT angio, and on the basis of CT angio you can go for thrombectomy. Okay, so this is very important diagram, and this thrombectomy is endovascular procedure. Okay, so this is ideal way to treat a patient of ischemic stroke. Okay, now try to understand, not all candidates of ischemic stroke should receive thrombolysis. Suppose a patient has NIHSS score less than 5. If NIHSS score is less than 5, this falls in the criteria of minor stroke. Though this person is having a stroke, but NIHSS score comes out to be less than 5, or if there is any bleeding manifestation, there is active bleeding manifestation. For example, INR of this patient is very high. For example, if this patient have had attack of MI in previous month. For example, if this patient has very high BP, that is more than 185 by 110 millimeters of mercury, then this patient is not candidate of thrombolysis. Okay, so you have to understand, not each and every patient of ischemic stroke has to be given thrombolytics. Okay, now here you can appreciate tissue plasminogen activator, that is retiplase. So if patient presents within 4.5 hours, you have to give tissue plasminogen activators. You can give retiplase, you can give alteplase, right? Take example of alteplase. You have to give at the rate 0.9 milligram per kg, and 10% of this dose has to be given IV bolus, and remaining 90% has to be given as what? As infusion over next 1 hour, followed by CT angiography, and then you can go for clot retrieval, and this is known as mechanical thrombectomy, right? Following that you can go for thrombectomy. Okay, in case there is any contraindication for this thrombolysis, you can go to thrombectomy straight away, provided that you have got the CT angiography. And here you can appreciate indication and contraindication of thrombolysis. I have already discussed that ideally thrombolysis should be done if patient presents within 4.5 hours of onset of focal neurological deficit, right? And provided that NIHSS score is 5 or more than 5. So these are the candidates of thrombolysis. But if there is any contraindication, then you cannot provide this thrombolysis, because instead of providing benefit, it can do more harm to patient. So you also need to know the contraindications. If blood pressure is more than 185 by 110. So this is contraindication of thrombolysis, because if blood pressure is that high, it might result into severe hemorrhage as well, right? If patient has active bleeding from any side, if patient have had recent MI, right? If patient had major surgery. So these are the conditions in which thrombolysis should be avoided. So in a nutshell, we have studied about treatment of ischemic stroke, but as of now we have mainly talked about treatment of thrombotic type of ischemic stroke. Now take a condition in which your patient had embolic stroke, and I have already explained that most common cause of embolic stroke is cardiac diseases. Take example of atrial fibrillation, take example of myocardial infarction, dilated cardiomyopathy, infective endocarditis, etc. So in embolic stroke, treatment will remain the same, but in embolic stroke you can also give anticoagulants after 24 hours of thrombolysis, right? And here you can give low molecular weight heparin. Apart from this, in case of stroke, you have to also give antiplatelet drugs, right? And drug of choice over here is your aspirin. No need to give anticoagulants in case of thrombotic ischemic stroke, and this antiplatelet drug has to be given. Antihypertensives have to be given to bring down the BP below 185 by 110. Last but not the least, you guys understand that you have to also use statins, right, to lower the blood lipid levels. Okay, so that's all regarding treatment of ischemic stroke. In next lecture we will talk about intracranial hemorrhage. Bye bye, take care.